Dr. Simon Knowles is a senior lecturer and clinical psychologist based at Swinburne University of Technology in Melbourne. He's a chief investigator and developer of an internationally known free online psychological assessment and treatment service for psychological distress associated with a burden of gastroparesis. Simon will outline the current understanding of psychological impacts on gastroparesis and provide insight into the latest treatment strategies available to improve patient quality of life. Please welcome Dr. Simon Knowles.
Thank you, Vincent. And thank you for having me here and having a chat today about a very important topic, but it's also something that is not necessarily a topic that's talked about a lot. So it's a great thing you've done to have this organised this day and to bring a range of experts together, and especially bring out the great Professor Calamari here to talk to us as well. So I'm going to talk about the psychology of gastroparesis, and it's in a way hard when you're presenting on a topic and you've had some eminent speakers come along and talk, and then you've had Emily and Ashley just so eloquently identify their experience of living with gastroparesis on a day-to-day basis, and I hope my talk will really identify some of the things that they really well identified, and I think the video is something that I was really impressed by. So I'm also mindful of time, so I'll try to catch up so that we're not too delayed from afternoon tea. So essentially I'm going to go through talking about why focus on the gut. Why would a psychologist in all his mind want to focus on the gut? There's only a few of us in Australia who actually specialise in this in gastroenterology, and so I'm one of them. I'll go through very quickly the basic facts of gastroparesis, but it's been covered already today, so I'm literally going to show the slide. And then what I thought I'd do is I'd talk through 4 studies that we've been working on for about 3-4 years with my PhD student who's just about to submit their work. And so I thought what we'd do is go through some of her hard work. And then we'll talk about when should psychological intervention be helpful. So if you would ever want a copy of my slides, feel free to get in contact with me. If you'd like to have a chat, please feel free to get in contact with me. So the first thing is, why focus on the gut? Well, one of the first things to identify is that if our gut's playing out, it's not going to make us feel really good. In both up here, we're going to might feel stressed, we might feel anxious, we might feel depressed. And, some people go, why would a psychologist be interested in the gut? And, why they connect? They don't seem to be connected. And I usually ask a question which is, well, do you remember going out on a first date, or maybe you haven't, or maybe you might in the future? If you are so lucky, if you do go out on a date, or hey, if you have to give a public presentation, what do you notice? And they usually go, your gut first. And go, butterflies in the tummy? Yeah, well, there you go. A stress can affect the gut. And so for me, with my patients, one of the key things is that when they feel stress, their primary problem for them is not necessarily what's going on up here, it's what's going on here. And that then plays this way. So you have this bi-directional pathway. And so it's great that they become aware of that, and they probably are, and they certainly are aware of the significant impact upon their psychological symptoms on their quality of life. Today we've heard quite a lot about that, about the impact upon gastroparesis. But it's also one of these things which is talking about the problem. As we saw, we can watch the video and we can see some people who look very well, but not necessarily actually are. They can be in pain, as we mentioned, 24 hours a day. They can feel the idea of eating food is nauseating. So it's something that can be difficult to talk about. But the other thing that's also really difficult to talk about in the community more generally is mental health. So combining the two is like a double whammy. And so for many of my patients, there's that added frustration. There's a frustration that I'm feeling depressed, I'm feeling anxious, I'm feeling alone, I'm feeling isolated, and I've got these symptoms that are going on which I have no idea about how to control and where I find support for them. And so there can be the stigma again, as I think Ashley really eloquently identified I think it was a picture of her sitting there where she looks very well, but that's not what actually is going on for her. And so again, it's this difference between observable versus hidden illness. And then, of course, you've got the family advice versus professional advice. And some of that is it comes from the heart. Well, you just have to eat small bits of apple. That'll help. Or drink small bits of water. That will help. And, of course, that's all very well, but you're not the one living that experience. And, of course, I think, as was identified earlier, the significant frustration that can be associated with living with conditions like gastroparesis. So again, we've identified unknown cause. There's concerns about GI-related emergencies. Do I have to carry around a separate pack so I can make sure I get to the hospital in time? There's the idea I'm feeling a bit better today, but does that mean tomorrow's going to be an even crappier day? Obviously, there's eating and digestive problems. And then there are social problems. Here we are at a social event, obviously maybe not necessarily the most exciting you've been to, but it's up the top, I suspect. Is for me anyway, that we have a social event. And of course, what do we do when there's a break? There's food. Why not? This is what we do. We're social creatures and in like food. So we go and have food, have a drink, maybe some alcohol, etc. That's all great. But for my patients, that can be incredibly frustrating because that's one of the problems is the idea of having something to eat and the impact that will have. Will I be well enough to sit through Simon's talk? I love this quote by Falk. It's the gastroparesis has been referred to as undoubtedly one of the most frustrating disorders in gastroenterology. I suspect I could talk to gastroenterologists who would say yes, and I suspect I could talk to patients who go, double yes. So, as we've identified, we see there's a greater predominance of females that have gastroparesis, and we're also aware of the symptoms. And there are different etiologies for that. I don't necessarily need to go into that. Now, there's been a series of numbers being talked about. The number I found was that at least 120,000 Australians have gastroparesis. The other area in which I work is inflammatory bowel disease. That has 75,000. So there are much more people that have gastroparesis, but I think in some ways there's more awareness of, say, inflammatory bowel disease than there is about gastroparesis. So we know that the symptoms can be incredibly debilitating for sufferers and impact nearly every aspect of their life. Their ability to work, their ability to socialise, their ability to plan, all the things that we often take for granted can be significant problems for this cohort. So, like all research, we depend on great PhD students. And so the following slides that I'm going to present are from my PhD student, Sally Woodhouse, who spent the last 3 or 4 years undertaking her research looking at the psychosocial impact of gastroparesis. I was the primary supervisor, and the very great Professor Jeff Hebbard was the associate supervisor. So I'm going to go through these studies relatively quickly. The first thing we did was we went, well, let's actually find out what the literature says with regard to the psychological impact of this condition. We then looked at what are the levels of psychological distress, so anxiety, depression, and quality of life. And the third thing is, are there any psychological interventions out there? And if there are, which we'd like, do they actually work? Not necessarily to resolve gastroparesis, but to improve the psychological well-being of individuals and also the quality of life. So, like any systematic review, we looked at lots of articles. Within this area, there are about 2,000, just over 2,000 articles. But when we broke it down to those three simple questions that I brought up, there were only a few studies, which suggests that what we see within this area is we really know, as it talks about, we don't necessarily know what causes gastroparesis, we don't know exactly what works, but from a psychological viewpoint, we know even less. What we do know is that in terms of the prevalence, that the rates of psychological symptoms are high. So in one study, 50% of individuals presented with significant somaticization. So it might be gut-based symptoms, as you'd expect, and other peripheral symptoms, pain, etc. So that's not necessarily surprising. 30% have a comorbidity of psychological symptoms. Now, if we think about 20% of the normal population would have symptoms, this group has 30%. And I suspect when we're talking about when the symptoms are at their worst, the psychological symptoms will be much higher, understandably. Parkman, another great researcher that works along with our guest speaker here, is about 22%. So we do see rates of depression and anxiety overall about 30% in this cohort. Oh, wrong computer. Sorry about that. So we know it's prevalent, but what about the levels? Well, again, a series of studies have looked at this, and what we see is that, again, actual rates of anxiety are about 36%, depression up to 41% of the cohort will have depression, and overall, again, 29%. That is with severe rates of psychological distress. So again, what we're seeing is this group, understandably, as you'd expect, has significant rates of mental health concerns. But what about in terms of quality of life? Well, as you'd expect, compared to healthy controls, it's much lower. We would also find similarly that probably across other illness cohorts, the rates of quality of life would be similar or lower. It just depends on the study in which you look at. So overall, the quality of life is poorer in gastroparesis samples compared to the general population. And as you'd expect, greater gastrointestinal symptoms, gastroparesis symptoms, are associated with poorer quality of life. So that doesn't sound really good. So therefore, what can psychology do to help? Well, let's try and run an intervention and see if that helps. Unfortunately, there is only one to date, only one published study that's actually looked at undertaking a psychological intervention for a gastroparesis cohort. It's quite a good sample size, 120 for a psychological intervention of this type. Has 60 control, 60 intervention, and it was basically while they were a patient in the inpatient service, they were met with various team members who provided either support, counselling, music and massage, and all aspects of, as well as the traditional conventional therapy that so everyone got that. And so what did they find? Well, essentially the depression scores and gastric symptoms were significantly improved. So while it's only one study, it did suggest that a psychological intervention did seemingly help both improve mental well-being, but also have an impact upon the gut functioning as well. But as we have to always note, this is one study and has not been replicated to date. But it's still significant and it's a good start. But again, this was 2014 and there's been none since then. So in our research, what we did was we sort of went back to, let's actually find out what's going on for people and get their experiences who have gastroparesis. So we did a qualitative interview. Well, sorry, when I say I, it wasn't me, it was my PhD student. She did a qualitative interview of 10 patients that had gastroparesis and asked questions about how does it impact upon their relationships, their personal health, their well-being, what do they manage. And so it was really interesting to hear the speakers today and Emily and Ashley, because some of the themes that they very rarely identified were also things that we found. The sense of frustration, the frustration of having to live with gastroparesis, the burden that it places on not only themselves, but also the people around them, or they feel the burden that's placed upon them. So things that they say are things like, some people just say to you, get over it, you'll be fine, get over it. For many years I was told that it must be an eating disorder because it had no medical name. So again, that sense of a lack of understanding. The other part that seemingly was very important to understand with this group was about its identity, the impact of gastroparesis had on who it made them. And the interesting thing about, from a psychological viewpoint, I'm always fascinated by how can I help a patient? What is the thing that's going to make that patient get from feeling depressed or anxious to feeling better? And in part, it's about their sense of illness identity. And this is shown here. So one person said, I will not make this invalid out of me. And that is a very strong strategy, a coping strategy, which ultimately means that the way in which they cope will be more productive rather than maladaptive. Another positive one is, I think this will make me stronger. I've been able to learn just how strong and resilient I can be, Given something's massive, you learn about yourself well. So again, they start to learn about the coping strategies that work for them and how they can overcome that. From understanding how it impacts upon their identity, it then can in turn inform the way in which they cope, as I sort of alluded to. So if they have a positive way of seeing things, a sense of agency, they're more likely to engage in strategies that will help facilitate the ability to cope with the symptoms in which they have. That doesn't mean the symptoms will necessarily disappear, but they'll be able to better adapt to having them. So again, the last comment I think really hits that. A positive attitude towards anything will help you feel better. When we put these together, you sort of have a downward pathway. We have this idea of the theme, which is the burden placed upon the illness. You then have the impact, or how they see it in terms of their sense of identity, and then in terms of a way in which they cope, or in other words, adapt to the condition and the symptoms of which they're facing. And this is important because it ties to a research model that I use quite a lot called the common sense model. And the common sense model basically says you have disease activity, disease severity, which correlates very well with illness outcomes like quality of life. But if I just looked at these two measures, they correlate or relate to each other by about 0.7, 0.8. But what this model says is that it's not just these two factors that are important. What actually determines someone's outcomes, like their level of depression, their anxiety, is mediated by the way in which they perceive their illness and also the way in which they cope. And so, with the kind support of many gastroparesis sufferers, they completed a questionnaire for me, which is just been accepted and about to come out within the next year, I would hope. And again, we had just under 200 gastroparesis patients complete a questionnaire to look at this model. And in essence, here is the finding, that basically, that the influence of gastroparesis symptom severity on psychological distress was fully mediated by illness perception. So in other words, that it wasn't the severity of the illness that impacted on the quality of life, it's how they perceived the illness. The other thing that was also important was that the way in which they coped. And in this case, adaptive coping, so helpful-based coping, didn't actually end up in the model, but what was a really key part of impacting upon quality of life and psychological distress was the engagement in maladaptive coping strategies. I'm avoiding it, I'm wishing it away, I'll drink some more, I'll try to avoid the emotion. And by doing that, what ultimately that resulted in is an exacerbation of psychological stress and in turn poorer quality of life. So then, in the final study, what we did was we developed an online intervention. And these are not easy things to do. But part of my research interest is developing e-based interventions so that they're available for free for anyone who wants them, 24 hours a day, 7 days a week. Sometimes the server shuts down and that's another issue. But generally, if I can't control these things, it's available. And the other thing too I should note is that not only is it available, in this case, the gastroparesis clinic, to those who have gastroparesis, but if anyone who is working with people who have gastroparesis and wants to work from a psychological viewpoint, so social workers, counsellors, psychologists, anyone, if you want to, you send me an email and I give you full access to everything in this website. So, how large is this website? Well, it has around 50,000 words, it has 35 handouts, 18 information videos, and 11 audio files. There's a lot of material on this website. The other thing that this website also does is provide psychoeducation. It's a source whereby people who have gastroparesis can come here and get accurate information about gastroparesis. The intervention is a 6-week intervention, and it usually requires a couple of hours a week. It's based on a cognitive behavioural intervention, which is very well established as an intervention modality for the treatment of a variety of different anxiety, depression-based conditions, and it's also used for somaticization and to help people to manage many health-related conditions. So, what's in it? The first module is about what is gastroparesis and the role of personality and moving towards a positive future. The next is about reducing gastroparesis physical responses and distress through breathing. We'll look at other strategies like cognitive, challenging, unhelpful thinking patterns. Mindfulness is another strategy we've also put in there. And obviously, pain is an issue in gastroparesis. So we have a specific module on that. And again, when we think about pain management, the research will show that one of the most effective long-term is really a form of psychological support, psychological interventions to help address pain. So this is a screenshot. I apologise for the picture of that person, but it just generally shows you, the videos. I tried to get another actor in. I couldn't afford it. It has, that's what I wish I looked like. So we have information, again about starting the program. It's very easy, previous, next, you can log in, log off, etc. It has case studies, so when people complete it, they can read it and have this is not just only me going through this, it has real case studies of individuals talking about their experiences of using the program. There are a whole range of tracks which can be downloaded, MP3 files which people can put on their iPad, iPhone, whichever electronic device they wish to use, they can use it and play them. And again, they're chosen particularly for the purpose of, in this case, relaxation training. So the results, well, again, this is an online trial, so it's not a randomised control trial. It's an open trial. Anyone can get access to it. And as a result, some people log in, they might use it and not fill in the responses. And this is one of the problems. The rates of getting responses of actual, and when I say responses, it's providing the pre and post responses, is about 5%. It's very low. So this is one of the challenges I face in trying to provide evidence that it works. And so part of this is going to help me redesign it so I can get better that information. So essentially the results I'm going to show you is in a small sample size with I think there are about 6 or 7 completers compared to I think over 100 people who signed up for the program. So in terms of are there differences from those who completed versus those who didn't in terms of the baseline data? No, there were no differences. The trends indicated reduced symptom severity and psychological distress, improved illness perceptions and quality of life, and increased both maladaptive and adaptive coping in the post-intervention. So there was some improvement. And simply it's just shown here, because of the small sample size, from a statistical viewpoint, there's not enough power and there's not significance. So just from a sort of a thematic-based review of looking at those, what we see is that the majority did identify some improvement in terms of the gastroparesis severities, improvement in terms of how they saw their illness. They perceived they had more control over their illness. There was an improvement in terms of their adaptive coping, so they were more likely to seek help, ask, goal, plan, etc. There was a reduction in psychological stress and improvement in quality of life. They're all going in the right direction, except for maladaptive coping, which seemed to go in the other direction. And so we're still sort of scratching our heads at that. But essentially, my argument is it's such a small increase. I think if we had a larger sample size, we'd be okay. But we'll see as the research goes. But one of the really good things is that we did get some good qualitative information which will help us improve the website in the future. So, for example, many strategies have notably helped in particularly breathing in 4s and different thinking patterns and goal setting. Thank you for this opportunity to give me these strategies to manage my illness. And so, yes, there was some really good feedback. There was also some clear feedback, the idea of that, hey, this intervention seemed to be all about, this is all in my head. And I think, unfortunately, some of the things that I had said didn't seem to, that's what I was saying, that it's not all in your head, but sometimes people read into that it is. And so we've got to make that clearer. But for a free service that's still available, there's still much more work to be going, but I do like that people do find that it is helpful and that the feedback, even from a small group, was positive. So I'm pleased by that. I would like to thank Jeff for being involved in helping sort it out and making sure the information was accurate. If it isn't accurate, let me know and I'll talk to Jeff. And many of the other co-investigators. So let me just give just a brief comment about when should psychological interventions be used. Well, obviously when patients present with moderate or mild to severe psychological distress, if you're, for GPs out there or for people who want to use a psychological measure, something like the Kessler K10, if you look up K10, it's easily found. It's what GPs use to organise a mental health care plan. It has a score between 10 and 50. Above 20, mild symptoms are likely to occur. 30, you're in severe range, and so it's a very quick and easy measure to use. But even just asking, out of 10, how are you feeling? 0, the worst I've ever felt, 10, the best I've ever felt. That can be helpful just as a starting point. The impact of pain, stress, and emotional symptoms, getting a sense of that. If there are problems in that area, then a psychologist can be helpful. Stresses, relational problems, disease management problems, a psychologist can be helpful. As to the form of the psychological intervention, well, I think it really depends upon a range of things. The person themselves, what they want is one of the most important things, what they think will help. It's also the past history of what support structures or psychological interventions they've had and if they've been helpful or not, and the evidence of psychological comorbidity. You can use strategies that will be group-based or individual-based. Strategies like hypnosis, behaviour therapy, group therapy, stress management. You need a highly motivated client, no trauma history and no significant psychopathology. What we're seeing in this cohort is there can be a trauma history. I didn't touch on it, but Jeff did. And we also see there's a high rates of psychological comorbidity. And as a consequence, I think there is room for hypnosis, but it's not necessarily going to be my go-to at the start. Cognitive behavioural therapy, they do a lot of homework, so they need to be motivated. Interpersonal-based therapy, again, focusing on the relational patterns between the client and the psychologist, can be helpful, especially when there's complexity being involved. But having said so can CBT. So if gastroenterologist or patient concerns about psychological interventions, this needs to be psychoeducation. And one of the challenges is finding a good psychologist. And the other problem is finding a psychologist that has knowledge about gastroparesis. I can think about 5 in my head. And there's several thousand psychologists out there. So I'll keep on giving talks on this and hopefully getting the word out. But finding a good psychologist is really important, and often that involves going to a GP who does have a list of psychologists they trust. For psychologists, you can use a mental health care plan that's given by a GP. That allows 10 reduced cost sessions, and if you're lucky, you'll find a psychologist who doesn't charge at all and just uses the bulk billing. And in terms of psychotropic medications, as we've seen by a number of speakers, there are some medications like mirtazapine that can be helpful in terms of nausea and pain, and they can also help in terms of anxiety and depression. But again, that's something that really should be discussed with a gastroenterologist, a GP, and when in a complex situation, a psychiatrist. Obviously, the levels of motivation by the patient is also incredibly important, and how they seek and utilise psychological interventions. Obviously, I've talked about the mental health care plan. Another plan that might be helpful is the enhanced care plan, which allows access to allied health professionals like dietitians, physiotherapists, etc. If you are interested in finding a psychologist, one site to go to is the APS website. Otherwise, feel free to contact me and I will try to do my best. I have some on my website, which is mindovergut.com, there's no charge or anything like that. And the benefits of psychological support, well, who doesn't want to go see a psychologist? I mean, we're great. We are great fun. We're great fun, and we even finish early. So on that note, thank you very much.
Incredible. Thank you so much. Here's a token of our appreciation for you.
Wow.
Yep, it's for you. Thank you, and I'll get you to have this. You can see what I'm talking about. You can talk with Simon for hours on end about the gut. Simon, do you want to have a seat? And we'll give the opportunity for a few questions. Does anyone have questions for Simon?
Sorry.
I'm a dietitian. I'd like to say thank you for your online courses, because it's a really nice way to actually get patients who often struggle with the idea of the gut-mind link just into getting into some really practical solutions, and then you can then say, and would you like to go and see a psychologist?
Yeah, no, thank you. I think, one of the things that, I've been very lucky. I work at Royal Melbourne Hospital. I'm surrounded by excellent gastroenterologists such as Jeff Hebbard, Finlay McRae, and even around Melbourne, there's the amount of expertise. Peter Gibson, as you probably know, is also in Melbourne, and he's essentially the father of FODMAPs, and so to be around that group is really important. There's a very collegial aspect, and so my work. And often my work and working with other psychologists is educating them about the importance of not only the work that we do, but the importance of other specialists, including dietitians. So often we're working with clients who have dietary-based problems, like the food intake slow or whatever it might be. One of my first questions is, are they seeing a dietitian? If so, why not? And then how do we work together? And so often the successes I've had, when it does involve clients with food-based problems, is that interaction between the dietitian and the psychologist and the other health professionals has been one of the most important things. So, yeah, I try to replicate that in some of the... So my... another plug, my ibsclinic.org.au website has a whole section on FODMAPs.
I'm interested that the IBS side of things has about a 50% success rate with hypnotherapy, but obviously not with gastroparesis. It's a different mechanism in terms of the gut-brain link.
So, the thing to... actually, the rates for hypnosis and IBS are actually higher. I mean, the work by Warwell and colleagues, they produced they recently published a paper with a 1,000 patient audit, and after 5 years, the rates were still up to about 80%. It was really amazing. And so his team, but also the team over in Carolina and Paulson, those group there, they do show some great work. I think one of the challenges that I do think there's a great opportunity for psychological therapies within gastroparesis. Do I think it's actually going to improve motility? I'm not sure. I think there's a very strong biological motility-based process for that. But I certainly think it would probably help in terms of the psychological adjusting to that. But the problem is, with IBS, it's 1 in 5, 1 in 10 Australians, and I'm more likely to get a sample size there. With gastroparesis, while there is 120,000 individuals, it's difficult to get a population to be part of an intervention like that. But anyone who wants me to do one and get me people, I am keen to do that.